right, let's go ahead and get started. Welcome, everybody. Thank you all for being here today. Today, we have our webinar about long-term cancer treatment effects on cardiovascular health. We're so glad you can join us. Today's program is co-hosted by Cancer Wellness Center and the Leukemia Lymphoma Society with a guest speaker from Rush. This webinar is being recorded, and we'll send the link to the recording to everybody who registered. Now, before we get started, we'd like to share a little bit more about our organizations. My name is Amanda. I recognize some names here today. So thanks y'all for being here. I'm the Patient and Community Outreach Manager for the Illinois region for the Leukemia Lymphoma Society, aka LLS. LLS is the largest nonprofit dedicated to curing blood cancers and improving the lives of patients and their families. We fund research, we fight for policies and legislation to improve access to healthcare, and we provide support from the moment of diagnosis through survivorship. These support services include financial assistance, guidance from trained oncology social workers and nurse navigators at the Information Resource Center, educational materials like booklets and workbooks, help navigating clinical trials through our Clinical Trial Support Center, and emotional support programs like our online communities, online chats, and our Patty Robinson Kaufman First Connection program, a peer support program. And then LS, we also do educational programs like this one. We're so grateful for our partnership with Cancer Wellness Center. So now I'd like to pass it over to friend and colleague Savina Chacheva from Cancer Wellness Center.
Thank you so much, Amanda. Good afternoon, everyone. My name is Savina. I'm the Program Director at the Cancer Wellness Center. Just before we get started, I'd like to share more about the center and our free services. The Cancer Wellness Center was founded in 1989 as a nonprofit organization with a mission to improve the physical and emotional well-being of those impacted by cancer and their families. Our services, which are both virtual and in person, include education programs like the one this afternoon that aim to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, nutrition, and more that provide a holistic approach to healthy living. And support services, including counseling for individuals, families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and the link will be included in the chat. Today we have our guest speaker, Dr. Toshi Akwosa from Rush University Medical Center, who is going to present on the long-term cancer treatment effects on the cardiovascular health. There's a lot of fantastic information that you will get to hear today, so thank you so much for being here. We've got lots of questions that were submitted, and we'll do our best to get through most of them. But if you have questions throughout the presentation, please include them in the Q&A function of the Zoom. Now, before we get started, I'd like to introduce Dr. Toshi. Dr. Toshi Akwosa is a professor of cardiology and director of the cardio-oncology program at Rush University Medical Center in Chicago. She earned her medical degree from the Philadelphia College of Osteopathic Medicine and completed her internal medicine residency and cardiology fellowship training at the University of Chicago. Dr. Toshi's primary research interests lie in the areas of cardio-oncology and cardiovascular disease prevention. She has played a crucial role in launching several successful local, regional, and national initiatives aimed at advancing cardio-oncology and enhancing medical education, while also promoting collaboration within the medical community. She serves as a faculty advisor at Rush Medical for Rush Medical students and is acknowledged for her commitment to health equity. Additionally, she's actively involved in community education efforts. In this role, she sits in the Chicago American Health Association board and serves on the board of directors for the Illinois chapter of the American College of Cardiology. Dr. Toshi has made significant contributions to the cardiovascular field by mentoring numerous trainees and publishing multiple peer-reviewed research articles, book chapters, editorials, and review articles about cardio-oncology and cardiovascular disease prevention. She is the expert that we get to hear from today. Thank you so much for being here, Dr. Toshi. The Zoom room is all yours.
Thank you so much for that kind introduction, Savina. Amanda, it's been a pleasure working with you both so far, getting here. And Amanda mentioned earlier that you all have questions, and I'm hoping that by the end of the presentation that much of your questions would have been answered. So that is the hope, and I hope I do a good job of it. So we'll see. So I'm sharing my screen right now. Okay, everybody can see my screen? Okay, perfect. So this is our agenda for today. So we'll start off by talking about the impact of cancer treatments on heart health. We'll discuss statistics just a little bit, understanding cardiotoxicity associated with cancer therapy. We'll discuss long-term effects of cancer treatments and then preventive measures, generally speaking, when it comes to heart disease and cancer. So this is what we have in terms of statistics. This is from the American Cancer Society, Cancer Facts and Figures 2024. We can see here that the new cases of cancer that we have in the United States is mostly prostate for men, breast cancer for females, and lung cancer for both men and women. But other cancers also affected by much of the population, right? As you can see here, and that includes leukemia, lymphoma as well. And when we're talking about cancer deaths, again, lung cancer comes to the forefront because it affects both men and women, so it affects more people as a result. Now, prostate cancer still is number one for men, and breast cancer still is number one for female when it comes to death from cancer. So, but the beauty of I would say when I was in med school, when we talked about cancer therapies, when we talked about cancer, especially the cancer is metastatic, oftentimes it was a death sentence, right? So you think about cancers like melanoma, even lung cancer, especially if you're talking about small cell lung cancer and other types of cancers, even metastatic breast cancer. But now there's been a lot of progress that's been made when it comes to cancer treatment, right? So much of the progress that's been made has now increased the number of cancer survivors. So as of January 2022, there were 18 million cancer survivors, which is about 5.4% of the population. So 1 in 20 people, and I know most of you probably already know all these figures, that number is projected to increase to about 22 million in about 10 years and to about 26 million by year 2040. So this is very relevant that as we're making a lot of progress with respect to cancer therapy, we are getting more cancer survivors within our population of patients. Well, the thing is, as I already mentioned, cancer death rates are decreasing, but here's the reason for this talk, that as cancer death rates are decreasing, cardiovascular disease risk is increasing, right? So we're talking about breast, melanoma, prostate, all of these cancers, all of them have sets of either cancer itself or the treatments that we're using for the cancer that increase the risk of cardiovascular disease and the risk of heart attacks, strokes, heart failure, particularly hypertension, and all the other things that we can see. So here's an example, right? We talk about a cancer patient that has cancer or has a history of cancer in red, now a cancer survivor, and their sibling in the gold lines. You'll see that when you think about other organ systems, right? So problems with hearing, kidney problems, visual problems, respiratory problems, those increase more in the cancer patient. There's no doubt about that. Oh, the cancer survivor as they age, there's no doubt about that. But the risk of cardiovascular disease is a major issue. And you can see here amongst the cancer survivor, the risk of having heart problems is much higher and actually gets very close to the risk of getting new malignancy as a cancer survivor compared to their sibling who never ever had any cancer. So this is the reason why we have to think about heart problems in this population, because it's one of the major issues that cancer patients and survivors face. And part of the reason for that is that the heart does not have much of any reserve to it. So the heart is an organ that's damaged very easily, is affected by systemic problems, like if somebody's under stress for whatever reason, maybe they have a bad infection or they have the cancer treatment, or other things happening to them, the heart gets affected very, very easily. And the heart is not resilient and does not have the capacity to regenerate itself or to recuperate unless you give it space and time to recuperate. And that's the reason why the heart gets affected much more than any other organ even though it uses most of the power within the body to pump itself, because it, of course, it supplies blood to all the other organs. So you can see here that as anybody ages, their cardiovascular reserve, or basically the risk of having heart issues, increases as people age. But that's expected, even if you're healthy overall. If you have cardiac risk factors, that risk is also higher, but that risk is even much higher in the cancer survivor. In other words, the cardiovascular reserve decreases with time as cancer survivors age, because in addition to typical cardiac risk factors, these people also have their cancer treatment as part of the problem. That can affect their heart and other issues. What are the common kinds of cancer therapies that we tend to think about in our population of patients? We think about chemotherapies, we think about targeted therapies, immunotherapies, radiation therapy, stem cell transplant, CAR T cell therapy, right? So those are the typical broad categories. The world has developed so much and cancer treatment has developed so much. When I was in medical school and when I was training in residency and even fellowship, my cardiology fellowship, what we knew about were chemotherapies, radiation therapy, and stem cell transplant, which was called bone marrow transplant at the time. That was it. All these other things, targeted therapy, immunotherapies, CAR T cell therapies, those are all newer therapies. And that's beautiful because our cancer patients are living longer, right? So when we talk about heart disease among cancer patients, 84% of children with cancer will survive over 5 years. And that's great because, again, that speaks to the progress that's been made with respect to cancer therapy. However, when you look at it, you can see risk of heart issues like congestive heart failure, heart attack, pericardial disease or disease of the sac that the heart sits in, valvular disease or heart valve problems. All of those increase amongst these kids that are cancer survivors. And when you look at cardiac events, any of these events is up to 5 to 6-fold higher in our cancer survivors compared to their siblings. And you have 30-fold to 30 times higher risk of heart disease, death due to heart disease or death due to heart attack in this population amongst childhood cancer survivors. So people that had cancer as kids and are now getting older with their cancer because they have longer time to suffer the consequences and the problems associated with their cancer therapy. So this is very, very relevant. And you can see this is old data. As you can see here, 2009. I was just telling Amanda and Savina that we just published a new set of papers, not published yet. We finished writing it. It's yet to be published. So that's coming soon so that we have more updated data. So the overlap between cancer and heart disease, basically we are identifying a whole bunch of factors that connect heart disease and cancer, or that are linked between heart disease and cancer. Age is one of them, and then of course sex, tobacco smoking or cigarettes, we all know that. Genetics is also another influence that can be linked with both. And then other things like cardiovascular risk factors, typical cardiac risk factors, diabetes, obesity, hypertension, cholesterol problems, link both, right? So people that have one are more likely to have a problem with the other. Generally speaking, things like infection, things like inflammation, even if you're talking about inflammation from diseases like lupus or rheumatoid arthritis or Sjogren's or ankylosing spondylitis and so on, all the things that create inflammation, even infections can link these two disease processes together. And then there are other more recent genetic and stem cell markers that we're discovering, like clonal hematopoiesis, telomere length, and so on and so forth. So there's so many factors that link cancer and heart disease. And the reason that's important to talk about is because that means that people that have cancer are at higher risk of heart disease, even just by virtue of their cancer, before you then add cancer treatment, and vice versa. People that have heart disease are also at higher risk for developing cancer, or if they've had cancer, they're at higher risk for having bad outcomes from their cancer as a result of the fact that they have heart disease. And this is the sort of picture that you get. Again, some of these shared risk factors, and then you add the cancer therapy on top of that for patients that already have heart disease or heart disease risk factors. And this is the reason why we end up having problems amongst our cancer patients, generally speaking. So amongst those that are currently on cancer treatment, what's the problem with this? If they're getting cancer treatment and then the cancer treatment gets interrupted, then, they're having cancer, receiving cancer treatment, and then they end up developing heart issues or cardiovascular disease, then there is a higher risk that their cancer treatment is going to get interrupted. And that's a problem, because if the cancer treatment gets interrupted, what happens? That means that their cancer has time to progress, right? And that's a problem. So we don't want the cancer treatment to be interrupted. So usually as soon as the oncologist discovers there's a problem with their heart while they're getting cancer treatment, or even at baseline, before the oncologist starts the cancer treatment, if there's going to be any cardiac concerns, either because of the treatment or because of the risk factors that the patient has as baseline, the oncologist will usually refer to our clinic, to cardio-oncology clinic, because they want to make sure that our patients get taken care of, that their heart problems are being managed so that there is no risk of interruption as they're receiving these cancer treatments as well. There's also the risk of modifications to the therapy. What does that mean? That basically means that the oncologist will say, okay, you know, this drug I was going to give this particular patient would have done very well for them. Maybe would have cured their cancer or even staved off their cancer for many, many more years. But because now they have heart problem, nobody can live without a heart. So that's really important to take care of. I'm going to switch to a different therapy. May not be as good as the original therapy that I had planned, but what can I do, right? So that's part of the reason why we end up managing or co-managing our patients with the oncologists. And then optimization of treatment plans, right? It's very, very important for making sure that there's no interruptions and there's no unnecessary modifications to the cancer therapy of our patients as a result of heart problems or heart disease. So when we talk about common cancer drugs and potential risk for toxicity, you can see the list. It's longer than this, but these are some of them. And so this is here on the what we would call the y-axis, right? And then on the x-axis, you can see all the different kinds of cancer cardiac problems or heart problems that patients can have, from arrhythmias to cardiomyopathy or heart failure to arterial vascular disease, so problems with the heart arteries, to problems with the veins or clots in the veins, to something called pulmonary hypertension, which is hypertension in the lungs, to systemic hypertension or high blood pressure. Now, when I talk about high blood pressure, I don't mean blood pressures of 140s or 150s or 160s. Some of these patients, depending on the cancer treatment they receive, if their blood pressures aren't managed very closely, can have blood pressures as high as 200s, right? Which is very, very scary because they could easily just have a stroke from all that. Pericardial disease or problems with the sac that the heart sits in, or even myocardial disease, which is problem with the heart muscle itself, and valvular heart disease. So these are just some of the sort of cardiovascular issues or problems that we can see in cancer patients, which can be pretty detrimental depending on the kind of cancer treatment that you're talking about with our patients. So other things, hormonal therapy that was not mentioned, endocrine therapy or hormonal therapy, endocrine therapy used in breast cancer like aromatase inhibitors or tamoxifen type of medication, or androgen deprivation therapy that's used in prostate cancer. And then, of course, the stem cell transplant like I had mentioned earlier. One drug class that we always talk about are the anthracyclines, right? So that includes a drug called doxorubicin or adriamycin is the other name for it. This particular drug is really how the concept of cardio-oncology or the concept of understanding that cancer treatments can affect the heart. That's how we came in. This drug was the reason why all of this came into being, right? And I'll go back and say the first set of chemotherapies that were used for patients for cancer were the nitrogen mustards, which were really used around the time of World War II. And that was all people had for cancer treatments. We don't even use nitrogen mustards much anymore now. And then in the 1960s, the anthracyclines or the drugs like doxorubicin or adriamycin came into being. But it wasn't until, and they started using them in the 1960s, 1970s, but it wasn't really until the 1990s when we started having more advanced ways of diagnosing disease, especially diseases of the heart, that we began to realize that these drugs actually cause major cardiac issues and cause major cardiac problems like heart failure. And so this is a very, very relevant issue. You can see this particular drug, the doxorubicin, the anthracyclines, can cause all kinds of problems. They can cause heart failure. They can increase stress response. And so the heart is very responsive to stress, like I said earlier. And if you add all these other problems like pre-existing heart disease or diabetes or high blood pressure, cholesterol, and the rest of them, then you increase the risk of having heart failure that's associated with this drug. And it's important to note that this particular drug or drug class, as you're going to see in the next slides, all the different drugs that belong to this class. The problem with this class of drugs, they're given to kids because we use them for childhood leukemias, childhood lymphomas. They're given to adults. We use them for breast cancer. We use them for lymphomas, particularly. We use them for sarcomas, use them for certain types of leukemias. And so all these drugs, on this particular drug that we use for all these kinds of cancer, you can imagine all the cancers I've mentioned affects a huge population of patients. But why are we still using this particular chemotherapy? Because a lot of these cancers are so responsive to it. For example, lymphomas and even some of the leukemias get a cure from using this drug. Same thing with some of the breast cancers. And so even though it can be toxic to the heart, it is necessary in patients that use it that they actually do use it, because that's the only way to get a cure. So we use it, but then we also have to remember the cardiotoxicities that can result from it. And so it's important then that the oncologist thinks about it ahead of time, discusses it with the patient, educates the patient. And if there's a need to include a physician that needs to co-manage this patient's heart issues so that this drug does not become an issue for them, then we need to do that. We need to work in a cohesive group to be able to manage our patients who have problems with this drug. And even not just while they're treating the patients, because the risk of toxicity from this particular drug class is a lifelong risk. So you receive that treatment now, and we see this a lot in our pediatric patients. They receive the treatment when they're 7, 8, 16, 15, that sort of thing. And then, when they're in the 40s or 50s, they could develop heart failure from this particular drug. And sometimes the heart failure happens immediately. And so this is very, very relevant and important to think about. And when we're talking about anthracyclines, there are different kinds of drugs in this class. Doxorubicin is the prototypical one, that's adriamycin. There's daunorubicin, there's epirubicin, idarub. They're all rubicin sort of drugs, as you can see. There's even the liposomal doxorubicin, which the risk of toxicity is less than the typical doxorubicin, but still has its own set of risks as well. And then there's the liposomal daunorubicin, and then other regional variants like pirarubicin and idarubicin and so on and so forth. So these are commonly used drugs, again, for the different kinds of cancers that I mentioned. And this is what happens when we use these particular anthracycline class of drugs. This is a normal heart. You can see how it has this ellipsoid shape, is the way we describe it. It looks really nice and cool. And then this is a heart that's suffering after it's received doxorubicin. This is the sort of thing that we tend to see. The heart is distorted. The pump function of the heart, or what we call ejection fraction, is reduced. Heart isn't squeezing so well anymore. And this is a major problem, because if these patients develop heart failure, we try to manage them as best as we can. Sometimes we're able to, but sometimes we're not able to. And these patients may end up on the transplant list, assuming their cancer is no longer an issue. Their cancer remains an issue, then of course they can't end up on a transplant list. So again, this is something that's very, very important to think about. And the toxicity from this particular drug can be acute. In other words, it can happen while the patient is receiving treatment, like within a couple of days of receiving treatment. And when that happens, usually that tends to be reversible. Usually when the treatment is stopped, that usually gets back to normal. So those are not the people we worry about as much. The people that develop subacute toxicity, so the people that within a year of receiving treatment, that's where much of the population of toxicity, cardiotoxicity, or toxicity to the heart from this particular class of drugs results. It's usually within a year. So oftentimes, if they receive this class of drugs, we get an echo right after they're done with treatment. There's usually a lifetime dose limit that it can't really receive beyond that lifetime dose, because the risk of toxicity is much higher, the higher the doses that we give the patients. And so within the first year, after they're done, then within the first year, they're gonna need another echo or heart ultrasound just to make sure that their heart function is staying stable and it's not getting worse. Because if it is getting worse, the earlier we recognize it and start to treat them with medications, the better, and the higher the chances that they're gonna recover their function to at least close to normal, if not normal. And then there are the late toxicities. These are the ones I was talking about with childhood cancer survivors and even adults that receive this drug. Depending on the dose that they receive, they may need to be followed for the rest of their lives just to make sure that their heart is doing okay, and they're going to be getting echoes every few years. And so this late toxicity does exist, and this is something that I have to talk to my patients about on a regular basis, just to let them know, the fact that you're done, the fact that you're cancer-free, and the fact that you don't have any toxicity to your heart right now doesn't mean that later on it's not going to be an issue. And so you can see here the reason why we have to kind of monitor these patients closely. In this particular study shows that if patients develop heart failure from the doxorubicin, if we recognize it within the first few months, we have higher chance of getting their heart function to be back to normal, because we're going to put them on medications to help strengthen their heart, and then the chances of recovery is higher. However, if we recognize that they have a problem later on, chances of heart function recovering to normal is basically almost 0%, as you can see in this study. And so early recognition becomes important, especially with this class of drugs called anthracyclines. What are the risk factors for anthracycline heart dysfunction? The dose, like I mentioned earlier, is a particularly important point. That is the single most important reason why people end up developing heart failure is the dose that they receive. So for example, we know that at doses above 250 milligrams per meter squared is usually where we start getting concerned regarding the heart of the patient. Breast cancer patients tend to receive 240 milligrams per meter squared. So they just kind of fall under that radar. Lymphoma patients tend to receive 300 milligrams per meter squared, so they're at higher risk. Sarcoma patients tend to receive somewhere between 420 and 450, so their risk is even higher. So again, depending on the kind of cancer treatment we're talking about, that risk could be higher in some people compared to others. And so it's important that the physician that's treating the patient's heart issues are aware of the dose, are aware of these issues, and how best to manage them. The length of time after treatment is so the risk is higher as people age, but again, within the first year is when you have the highest risk. The rate of administration of the drug and a whole bunch of other logistic issues. If they've received radiation along with the treatment, that also increases the risk. Other sorts of cancer therapy like anti-HER2 therapy that we use for breast cancer, like trastuzumab or Herceptin, is also a problem. If they have pre-existing cardiac risk factors, particularly hypertension. And I always tell my patients, you got to make sure your blood pressures are well controlled during treatment and after treatment, and even as 10 years, 20 years after treatment, because that's very relevant. Blood pressure, if somebody has high blood pressure and they've received these class of anthracycline drugs or other kinds of chemotherapies, the risk of developing cardiotoxicity, particularly heart failure, is up to 3 to 5 times higher than people who did not have high blood pressure in this population. So again, blood pressure monitoring and management is particularly important. Age is another thing. Kids less than 16 years old and adults greater than 85 are at higher risk for developing problems after receiving this drug. And there are some studies that suggest that women are at higher risk compared to men. So this is all relevant. Switching gears a little bit, talking about anti-HER2 therapy or drugs like trastuzumab or Herceptin, lapatinib, and other sorts of anti-HER2 therapies that we use for breast cancer, adutrastuzumab, and so on and so forth. They also increase the risk of heart failure in certain patients. And so, but the risk of heart failure, unlike doxorubicin, where the chances of recovery once they've developed heart failure is pretty low, with these class of drugs, the chances of recovery is higher. It's not 100%, but there's a higher chance that these patients will recover. Who are the people that get anti-HER2 therapy? And there's a relevance to that. Those are breast cancer patients for the most part. And then other sorts of malignancies, like some GI cancers can also use it sometimes. Some of the gynecologic malignancies can also use it sometimes, and so on and so forth. So it's important to know about this class of drugs, because if patients, again, like I mentioned earlier, if the patients develop heart failure, there's a chance of recovery. However, a lot of HER2 positive breast cancer treatments use it. They have to use it because if it's HER2 positive, it makes sense that they would use an anti-HER2 in order to try to obtain a cure. Now, if they have metastatic breast cancer, first of all, if they're getting anti-HER2 therapy, they get it for a year. So they have a whole year of exposure to these drugs to develop cardiotoxicity and heart failure related to these drugs. So that's very, very relevant. And on top of that, if they have a metastatic breast cancer, then they're basically going to receive anti-HER2 therapy for the rest of their lives. And that is very relevant again, because the patients, the more exposed they are to these anti-HER2 drugs, the higher the risk of heart failure. So that's important. I've had patients in my clinic that they've received anti-HER2 therapy for 10 years. And now they're having heart failure as a result. Now, that's difficult because if you stop the anti-HER2 therapy, the cancer progresses, and then the risk of dying from the cancer is even higher. So again, these are all drugs that's important for us to know about. And these are some of the anti-HER2 therapies that patients can receive. I talked about trastuzumab, which is Herceptin. There's pertuzumab, which is Perjeta. There's the TDM1 drugs, lapatinib, and so on. There's a long list. But these ones, some of the VEGF, what we call VEGF inhibitors, which I'm going to talk about in a little bit, or tyrosine kinase inhibitors, also belong to this class of drugs called anti-HER2 therapy. And you can see this basically just shows a slide about the reversibility, the fact that some of these drugs, the toxicity to the heart can be reversed. But again, this is, you can't always take it for granted that it can be reversed, because a lot of it also depends on the duration of treatment that they're receiving. And then how about tyrosine kinase inhibitors? In my opinion, in everybody's opinion, these are the most prolific type of cancer drugs out there. For any kind of cancer you can think of, there's some sort of tyrosine kinase inhibitor that can be used to treat it. It may not necessarily be a cure, but can be used to treat it, especially if that particular cancer is metastatic. And so these classes of drugs are particularly important to know about and to think about. And there's a long list of those drugs, as I will show you in the next slide. Their claim to fame and the problems they can cause are things like heart attacks or arrhythmias, or they can also cause blood pressure problems. And blood pressure, these are the particular drugs that can cause blood pressures that can get as high as 200s. And I've even seen blood pressure of 300 in a patient that ended up in the emergency room of these drugs. And so the oncologists and the cardio-oncology specialists that's working with the oncologists need to be aware of this and manage these patients and control their blood pressure way ahead of time before it becomes a problem. And so usually once we start these drugs, and you can see a list of some of them here, once we start the patients on these drugs, we have to monitor their blood pressures right away. So within the first, because the blood pressures go up within the first week to 2 weeks of treatment, usually about 10 days on average. So monitoring is particularly important as soon as patients start these drugs, and then managing the risks that can come with it. And so you can see here, there's a long list. Like I said, imatinib, there was the very first one that was developed in 2004, I believe. And that was the very first one that was developed. But then, like I said, there's so many of them. And you can see they're used for all kinds of cancers, leukemias and lung cancer and lymphomas and a whole bunch of other cancers. So it's really a very relevant point that knowing about these drugs is particularly important. Just recently, I had a patient on one of these drugs that actually ended up developing, they referred the patient to my clinic because the patient developed a heart attack as a result of being on one of these drugs. So again, these things are things that we have to think about that can happen. How about radiation therapy? Radiation therapy can cause different kinds of heart problems, atherosclerosis or blockage of the heart artery, heart block, which basically means that the electrical rhythm of the heart is completely blocked and the patients may end up requiring a pacemaker. They can get tight or leaky heart valves as a result of radiation, which may end up needing cardiac surgery or cardiac procedure to open up or to take care of the valve. People on radiation therapy can get inflammation or fluid around their heart, which is we call pericarditis or pericardial effusions, which can be detrimental. It can be deadly if not managed appropriately. So that's important too. Racing heart or palpitations or arrhythmias can result from radiation therapy. Dysautonomia or autonomic dysfunction that can cause things like racing hearts that heart can race forever, all the time they're racing, or heart rates very, very slow, and that's the pulse can be very, very slow. Or they can get blood pressures that spike and then come down and spike and then come down. And that's a problem because I have some patients in my clinic, they have blood pressure 1 minute, 190s, the top number of the systolic blood pressure is in the 190s, and the very next minute, their blood pressure is in the 70. How does anybody live like that? And these patients, it really debilitates their lives. So knowing about this ahead of time, knowing that the radiation is the cause of this, and knowing how to manage them is particularly relevant in this patient population. And this is just a schematic or drawing that shows you a heart artery and how smooth it is at baseline and nice looking at baseline. And then they receive radiation therapy, they get all this inflammation, and this is what it ends up looking like in the end. You have fibrosis or scar tissue that forms within the inside lining of the heart artery, which can then lead to different kinds of radiation problems. Like I already mentioned, you can get heart artery blockage as a result of this particular picture. Other thing that radiation can also cause is distortion of the heart muscle, the heart muscle cells and the structure. So this is somebody who's getting a lower dose radiation and now they get a higher dose radiation. I can see how that heart muscle is being replaced by fatty tissue and so on. And these are the sort of things that can lead to heart failure, that can end up leading to really stiff hearts and a whole bunch of other kinds of heart issues associated with radiation. And radiation in the induced heart disease is dependent on the dose of radiation that the patients receive. You see it more with left-sided radiation because the heart is on the left side, obviously. If they have heart disease risk factors, that risk is higher. And then, of course, the past chemotherapy or cancer treatment they've received is also relevant. And sometimes the concomitant cancer therapy that they're receiving right then is also important as well. And I mentioned here, this can happen up to 20 years or more after radiation therapy. In fact, the risk of having heart problems as a result of radiation therapy increases with age. So let's say somebody receives radiation at the age of 30, as they get to age 40 and 50 and 60 and 70, the risk that they're going to develop one of these other heart issues that I talked about earlier is higher. And if they've developed it, the risk that it's going to get worse is also higher. So as time goes on from the time of radiation, that risk increases and expansions, basically. So breast cancer, patients receive endocrine therapy for breast cancer. I kind of mentioned this earlier. There's a selective estrogen receptor modulators like tamoxifen, raloxifene, and the newer generation one. The ones that we tend to use mostly for breast cancer would be tamoxifen. And then there's the aromatase inhibitors like letrozole and anastrozole, exemestane, which are pretty commonly used for hormone-sensitive breast cancer, as I'm sure many people know. The aromatase inhibitors would increase the risk of heart attacks and strokes and increase the risk of obesity, cholesterol problems, developing diabetes, those sorts of things. So we need to monitor them and manage them accordingly so they don't cause long-term risks, especially knowing that these drugs are usually given to patients. It used to be for 5 years initially, but now most of the patients are getting these drugs for 10 years. So it's particularly relevant in that sense. And then the tamoxifen type of drugs increase the risk of blood clots. So people can get blood clots in their legs, which can then go to their lungs, and if not discovered early, can actually cause death. So that's particularly important that people think about that as people are having these problems. They can lower bad cholesterol, which is the good thing, but the risk of clot is the main thing that we get concerned about. Drugs like cisplatin that are used for things like certain types of lung cancer, certain types of head and neck cancers, also particularly important that we kind of discussed very briefly. They're used to treat different kinds of cancers, and they can be detected in the blood up to 20 years after treatment. So this is particularly important to know. So because they can be in the bloodstream many, many years after, they can cause delayed cardiovascular toxicity. So over time, as these patients age, they're at high risk for having high blood pressure, cholesterol problems, heart attacks, and strokes as a result of these cisplatin type of medications. I guess that's the same thing I'm mentioning here. 6-fold higher risk of coronary artery disease and 3 times higher risk of having a heart attack as a result of these treatments. Hypertension is one of the problems that these patients can develop, and then cholesterol problems, I mentioned all that. Insulin resistance and diabetes as well. How about immune checkpoint inhibitors? Everybody has heard about immune checkpoint inhibitors or immunotherapies. I will mention that there are different kinds of immunotherapies, but immune checkpoint inhibitors are the particular ones that we tend to get concerned about the most when we're talking about the heart. And immune checkpoint inhibitors are drugs like pembrolizumab or Keytruda, the drugs like nivolumab or Opdivo. Those kinds of drugs are newer kinds of therapies that we tend to think about that can increase the risk of having problems like myocarditis or inflammation of the heart muscle. And I'll just mention very briefly how these drugs work. It's pretty cool the way they work. You have the cancer cell. Usually, if we have a foreign body or if we have a cancer cell that's kind of growing where it's not supposed to grow, our T cells or our own immune system is supposed to attack those cancer cells and kill it. And so there are a lot of people that we're about to develop cancer. Our cells attack those cells, kill it, and then we don't even think about it. Those people don't develop cancer. But then what ends up happening, some of these cancer cells are so smart that what they do is that they figure out a way to attach to our own cell and basically incapacitate our own cell. So our T cell cannot attack the cancer cells anymore. And the beauty of the immune checkpoint inhibitors is that they've developed, and these scientists are so smart, have developed receptors that can cause the drug, the immune checkpoint inhibitor, to attach to the cancer cell, then release the cancer cell so that the cancer cell leaves our own natural T cell free to then do what it needs to do, which is attack the cancer cell to kill it. So it's pretty cool the way these drugs work. And the guys that first discovered it basically ended up receiving a Nobel Prize as a result. And these are the kinds of problems that we can get with the immune checkpoint inhibitors. And these are the list of drug names for immune checkpoint inhibitors. As you can see here, there are many different ones, but they can increase the risk of Takotsubo or stress cardiomyopathy, which is stress to the heart, basically leading to heart failure, heart rhythm problems, and pericarditis, which is inflammation of the sac that the heart sits in. The same thing I mentioned earlier that radiation therapy can cause as well. Particularly from a heart standpoint, myocarditis, that's a problem. Now, the risk of having myocarditis is not very common with immune checkpoint inhibitors. It's really about 2% of the population that receive immune checkpoint inhibitors that can have this problem. But it's very relevant because as patients develop myocarditis from immune checkpoint inhibitors, the risk of death is about 50%. So 1 in 2 people that develop a myocarditis from this drug will die from it if nothing is done, if they're not taken care of right away, they're not recognized and taken care of right away. And so prompt recognition or recognizing these early is important. And a lot of patients that have been on immune checkpoint inhibitors usually know these drugs because they cause inflammation in other parts of the body, because our own cells are now free to do what they want, and they can basically rev up and start attacking themselves too. So people can get thyroid problems. That's usually the most common. So thyroiditis, which is like myocarditis, but of the thyroid. They can get pneumonitis, which is inflammation of the lungs. They can get adrenalitis, which is adrenal gland, nephritis, the kidneys. All organs can get affected. But again, when they affect the heart, we really tend to get bothered. And we have to make sure we do something quickly. Stem cell transplant has its own set of issues that we need to think about as well. These are all when a patient is being evaluated for stem cell transplant, these are all the kind of things that we have to think about when we're trying to figure out their risk of having problems as a result of heart failure. And this is a study that we published recently. We have to think about their age, cancer-related factors, other cardiac issues that they may have, their lab data, and so on. And then using that to assign risk levels and then decide how best to take care of them. And so these are the sort of problems that transplant patients can develop eventually. So you have a patient that's going through transplant here, stem cell collection, they get a transplant, and they can develop heart complications during transplant, during conditioning. They can get a heart attack, they can get AFib with abnormal heart rhythm, they can develop heart failure and so on. And then afterwards, long-term, they can develop heart artery problems or coronary artery disease or atherosclerosis. They can develop heart failure, they can develop diabetes and high cholesterol and so on. Increased risk of other malignancies or other cancers that can then end up causing problems to the heart as well. So when we're thinking, we kind of mentioned these broad categories of cancer treatments. Unfortunately, I can't talk about every single one of them, but you kind of get the picture. And when we're thinking about evaluating and managing people who have at risk for having heart problems or who already have heart problems as a result of their cancer treatment, there are a few things that we have to think about. The age, whether they're male or female, the genetics, whether they have heart issues from prior, what sort of cancer treatments that are cardiotoxic or toxic to the heart that they've received in the past. We think about we check their EKGs, their echo, their cardiac markers, which is the troponins and the BNPs. Those are lab data that we get on these patients. We look into their lifestyle, so we ask them very thorough questions about their lifestyle, and then their kind of risk factors, both with respect to diabetes, high blood pressure, and so on, but other comorbid conditions, like do they have COPD or not? Do they have peripheral arterial disease? Do they have immune problem like lupus or the rest of them, and so on. So all of these are things that we kind of have to take into account as assessing the patient's risk. And in terms of clinical risk assessment, we also have to do a physical exam and measure their vital signs as well. And these are all the complementary tests that, anybody that's presenting to my clinic gets all of these tests at baseline, because I want to make sure that I know what I'm doing in terms of figuring out the best way to manage these patients. It has to be a very comprehensive approach. It's not a one-size-fits-all for the patients that get treatment. The other thing I would have added to this test would be thyroid. I also do measure thyroid levels because those are very relevant for considering heart issues. And so new cancer diagnosis, they get cancer treatment. As time goes on, you have 1 year after treatment, long-term follow-up after treatment. When we're talking about cancer survivors, in the past, I guess 20 years ago, we would have said cancer survivor is somebody who has received cancer treatment, whether it's chemo or radiation therapy, and is now surviving their cancer and they're still alive, that sort of thing. But now, as I'm sure many of you know, cancer survivorship is kind of a different ballgame, because a lot of patients are now on pills for their cancer, and they're on pills for 10 years, for 20 years, for 30 years for their cancer. And so that's also a new breed of cancer survivors. These are patients who are living with their cancer, but they're living many years with their cancer. And so we also have to think about the cardiotox. Like I mentioned, I talked about the HER2 therapies, right? Because these are all cancer survivors that are living for many years, but we have to think about their cardiac problems, because we don't want them to be on cancer treatment or having gone through cancer treatment in the past, then come and die from heart disease. So it's important. And we think about the time, and that's what I was talking about earlier. And then we think about their risk level. So are they high risk? Are they moderate risk? Or are they low risk, depending on the sort of cardiac risk factors they have? And using that, we can kind of figure out how best to assess them, how best to manage them during treatment, and the sort of testing that we're going to need to get as they're living with their cancer as cancer survivors, or even after treatment as cancer survivors, years after cancer treatment has ended. And then we think about other factors in preventive therapy. There's the ABCDEs of preventive cardio-oncology. So we think about awareness of the risk of heart disease. Patients should ask, and these are things to empower you that you can also ask your doctors. Should I be on aspirin? What's my blood pressure? Know your blood pressure. Is it controlled or not? Because remember I mentioned the blood pressure is high, the risk of having cardiotoxicity from cancer treatment, either current cancer treatment or prior cancer treatment, is higher. So it's really important to make sure that that's controlled. Cholesterol, make sure you quit smoking. Diet is important, and weight management, right? There's studies that have shown that obesity increases the risk of recurrence of cancer or even cancer progression to metastatic cancer. So especially cancers like breast cancer and so on. So it's really important that our patients are receiving, a lot of patients, they get cancer treatment, they lose weight from cancer as they're getting cancer treatment. And then afterwards, patients say, oh, I lost so much weight. And then they go back and they gain all this weight. And I'm like, no, don't do this. Because you're increasing your risk, not just the risk of heart issues, but also your risk with respect to the cancer itself, the risk of the cancer coming back or the cancer spreading. So it's important. I'm not saying anybody should be skinny, but if people are gaining weight, number one, don't gain weight too quickly, because when you gain weight too quickly, you basically deposit a lot of fat around your organs, which then makes your organs toxic. It's very toxic to the organs when people gain a lot of weight very quickly. So number one, don't gain quickly. And number two, don't go above your recommended weight, right? You know your BMI, you know what your ideal weight should be, and try to maintain that sort of ideal weight. The dose of the chemo and radiation I kind of talked about earlier, that's important. Diabetes management is important. Exercise is specifically important. Honestly, if there's one of the most important factors in terms of survivorship years is exercise, because when you exercise, you don't just strengthen your heart muscle, because every time you exercise, you get your heart muscle to pump harder, which means you get to strengthen it that way. But exercise also is very beneficial because you get blood pumping to all your other organs. You clear waste products faster and easier with exercise. And you also supply necessary nutrients to all these other organs, and that keeps your other organs healthier as well. So exercise is important and relevant. And then the patient should ask the doctor, should I get an echo or an EKG? And this is just a different way of looking at things, and also thinking about things like genetic factors and family history and so on and so forth, all very relevant issues. What are some of the symptoms of heart disease that we should be thinking about and concerned about that should make you bat an eyelid and say, let me talk to my doctor about this? Chest pain is a major one. I think most people know this already. Shortness of breath is also another one that's very relevant. Leg swelling, or what we call edema. Leg swelling can sometimes, and all these issues could be other things causing it. It may not necessarily be a heart issue, but when you get these problems, you really should ask your doctor, should I be concerned? And if you're one of those patients that received cancer treatment in a cancer center, in a tertiary institution like Rush or Northwestern or University of Chicago, whatever, and now you're out back in the community getting treatment, you should be aware of all of these and be an advocate for yourself and ask your doctor, hey, remember I received this particular drug as a cancer therapy. Should I be concerned about my heart? Should this be one of the things? And if they're not sure, they should send you to someone who knows. We've developed a nice cohesive group within the Chicago area of doctors that do this sort of thing that I do. And so there should be at least someone somewhere that you can see. And if you're not sure, feel free to ask me through our colleagues like Amanda and Savina, and they can give you all the information that you need. Dizziness, lightheadedness, or fainting spells is also another major concern. And then palpitations. If you feel your heart racing or skipping beats, that could mean that you're having arrhythmias and so on. So this is the way we think about it. Heart disease risk factors and cancer diagnosis, bad combination, and because they receive cancer treatment, and then all of this leads to higher risk of heart attack, strokes, death due to heart failure, heart disease, and so on and so forth. But we can modify all of these with what we talked about: diet, exercise, stress reduction, smoking cessation, so on and so forth. It's really important controlling cholesterol and the rest of them, and then blood pressure, especially blood pressure. So that's very relevant. So in conclusion, we summarize the link between cancer treatments and heart health. We discussed different toxicities to the heart from the various cancer therapies. We highlighted the importance of monitoring the cardiovascular health or heart disease health amongst our cancer survivors, and also encouraged, and I am encouraging you all, on preventive measures and regular checkups to make sure that the cancer treatments received in the past do not become, and if they've become, do not remain a major problem that leads to long-term bad outcomes from a heart standpoint. And I'll take any questions. Thank you so much for having me.
Thank you, Dr. Tochi. So grateful to have you. Let me go ahead and put on my camera for y'all. So we had a couple questions that came through. Some of these questions you kind of touched on in your presentation, but I just want to double click on them. We specifically had a couple people mention, ask about if there are any recommendations for echocardiograms. And I just heard you talk to your doctor about that. Is there any other information that you can give them that's a little bit more specific?
Yeah, so generally when we think about echo, we have to, I can't be as very, very specific to being, Amanda, honestly, but I'll just say this because, and the reason I can't be very specific is because it depends on it depends on the cancer treatment that the patient received. It depends on the cardiac risk factors and the baseline cardiovascular disease of patients and other treatments that they've received and the factors surrounding their treatments and their cancer. So these are things that tend to be individualized. However, that being said, the general recommendation is if they've received radiation therapy, depending on what part of the body they received radiation therapy to. So for example, if it's the chest and it's for, cancers that actually directly affect the chest, and depending on the kind of radiation, the recommendation is to get an echo and a stress test every 3 to 5 years, again, depending on the circumstances. If they've received anthracycline or doxorubicin type of medications, then the recommendation is every 3 years, depending, again, on the cancer and the risk factors and so on and so forth. So I think that there's a lot of thought process. It's not a very simple process to say, oh, you have to get an echo every this often.
Yeah.
It all depends on the cancer treatments that they've received. And some cancer, I will tell you, there's some cancer treatments that we don't really worry about heart disease risk on. And patients receive these cancer treatments and they go back out in the community and are completely fine. It's just that some of the major ones actually can be toxic to the heart. So again, there's so many factors that it's very difficult for me to answer the question, but a lot of it has to be individualized to the factors that are surrounding each individual patient and their cancer and treatment.
And you touched on some of the specifics that they asked about in that response. So thank you.
Yeah.
Another question, another point that you also shared was you talked about, preventative measures and things to keep in mind, the A, B, C, D, E's of heart, is what I put in my notes. It mentions, avoiding cigarette, tobacco, like cessation. We had someone specifically ask about alcohol use. Do you have any comments on alcohol use and cancer survivorship?
Thank you for asking. So alcohol use in cancer survivorship. So I'm sure all of you have heard like the recent FDA warning regarding alcohol and so on. So alcohol, I would say it must have been about 15 years ago or so. There was this whole noise about alcohol that was made, and some studies suggested that the more alcohol you drink, the better your good cholesterol, and so it's healthy for the heart, and so on and so forth. I am here to tell you that this is just a myth. There are a lot of factors that were surrounding those studies that were not teased out at the time, that we're teasing out a little bit more now. Now, if you're drinking alcohol occasionally, you go out with friends, and, on a Friday night or Saturday, and you have one drink, or if you're having 2 drinks, maybe one relaxation drink during the week, that's not a major deal. But I specifically recommend that patients don't drink alcohol every day. And I also specifically recommend that patients don't binge drink. That's specifically important. Once in a while is okay, but never make alcohol drinking a habit. Because if, for example, we go back to doxorubicin or adriamycin, the risk of heart failure as time goes on, and even with radiation therapy too, is higher when patients have been drinking alcohol, because alcohol itself is a myocardial depressant. And now we're finding that alcohol also increases the risk of cancer. So there will be no reason for anybody to drink alcohol on a regular basis to say that it's going to do them any favor, because that's just not true.
I appreciate that. I have a couple more questions for you based on our chat, trying to make them a little more generic. Some of you folks who put in specifics. If anybody does have any final questions, feel free to put them in the chat and we'll see if we have time to answer them. But there was a question that came up towards the beginning. I think it was referring to when you have that Venn diagram of shared risk factors. And you highlighted diabetes. And then later I heard you share diabetes in other certain instances. Does that include both type 1 and 2 was the specific question?
Yeah, no, that's a very, very good question. When we talk about diabetes in this setting, it tends to be more type 2 diabetes. That's the one that tends to be studied the most because in adults, that's what we tend to see more. And type 2 diabetes is typically linked to risk factors like obesity and cholesterol and high blood pressure and so on and so forth. So that's what we tend to think about is more type 2 diabetes. Now, type 1 diabetes, has some genetic links, and there's still a lot that we're trying to understand between links between genetics of diabetes, high blood pressure, heart disease, cancer, that sort of thing. So I think that there's still a lot that needs to be understood, but for the most part, it is type 2.
Thank you. Appreciate that. And then submitted today and before during registration, someone asked about venetoclax.
Oh, venetoclax.
Yeah.
Yeah. So venetoclax we do use for certain types of leukemias, especially the chronic leukemias. And it is a drug that the risk of toxicity to the heart is on the lower side compared to, say, anthracyclines or doxorubicin type medicines, but that risk still exists. So the risk with venetoclax can increase the risk of heart failure. It can increase the risk of ventricular arrhythmias or having heart rhythm problems that can sometimes be detrimental. So it's important to know, but they're not common risks, but they do exist. So again, discussion with your cancer doctor would be important, and ask if it needs to be monitored.
Okay, great. And then along that same lines, anything else you want to emphasize into like next steps on how folks in this Zoom room can, be their best advocate for themselves with their doctors and talk about some of these risk factors?
Yeah, I think, sorry, I'm just going to go back on the venetoclax part. There's another class of drugs that tend to be used for CML along with sometimes along with or sometimes before or after the venetoclax types of drugs. And those are called the Bruton's kinase inhibitors, like ibrutinib or acalabrutinib or zanubrutinib. I'm sure some of you have heard of these drugs. There's a new one called pirtobrutinib. So these drugs can increase, actually, I'm surprised I didn't put it in one of my slides, but these drugs can increase the risk of heart rhythm problems. They particularly can increase the risk of atrial fibrillation, which can be a problem because atrial fibrillation, if somebody gets atrial fibrillation, they need to be on a blood thinner to prevent the risk of stroke. But then these drugs also increase the risk of bleeding. So it's important that the doctor who knows how to kind of co-manage both issues is aware of it. And it's also important that the patients are aware, because if you're having AFib, then your risk of stroke, especially because you have a cancer, your risk of stroke is higher with AFib. And so if nothing is done to manage that AFib that can result from this drug, it's not even recognized, because it may not be recognized. Not everybody's going to feel the palpitations from a heart rhythm problem. So if the patient is not feeling the palpitation and the doctor is not thinking about it, and they actually have an AFib, they could actually get a stroke. So it's really important that patients that are on these Bruton's kinase inhibitors, like I mentioned earlier, think about the AFib risk that can come from it and ask their doctor, should I get tested? How often should I get tested? And so on and so forth. So that's, I wanted to kind of make sure that I put that in there. And Amanda, going back to your question, you were asking what can patients do overall? I think generally I just say to my patients, be an advocate for yourself. Know these risks, these risk factors. Take these questions back to your doctor. Ask questions. You have a right to ask questions. So you can ask the questions when you're in clinic with your doctor, or you can ask by my chart. Write them down. If you have questions for your doctor, either have someone go with you that can remember these questions, because oftentimes if you're the cancer patient, you may not remember because there's a lot of stress in your life. You're dealing with cancer treatments and you're trying to figure out ways to kind of sort through things and all the multiple appointments that you have. If you're a cancer survivor, you may have chemo brain, which is a real phenomenon and a real thing. So your memory may not be as good as it used to be. And so maybe have an advocate like a family member or a good friend or so on that comes with you, or you write them down ahead of time so you know them. And I have patients that do that. And they bring these questions to clinic, and then they ask me questions and we answer them together, and then they feel good going home. So think about it and make sure that you're an advocate for yourself. It's very, very relevant, because not every physician, even not every oncologist, thinks about these issues. So it's important that patients are advocate for themselves. And of course, things like diet, exercise, and so on, like I mentioned earlier. And in terms of exercise, it's important that patients know that cancer treatment causes something called sarcopenia, which means muscle wasting. And a lot of chemotherapies are particularly notorious for doing this. And so if our patients, while they're going through treatment, are not exercising, that risk of sarcopenia is higher. And then after cancer treatment, it's really difficult then to kind of try to recover the function that you lost already. So I do encourage my patients, even if you're tired from cancer treatment, it's important that you do your best to exercise. And you don't have to run a marathon. Nobody expects you to run a marathon, but walking, Or even some of my patients that are not very functional, I say, just use the peddler. Get a peddler and use it when you're watching TV, sit in your chair and do it. Whatever you can do, lift light weights. One patient told me yesterday, I lift like 1 pound weights. I'm like, that's good. That's better because you do these things and once soon enough, that 1 pound weight is going to become very light for you and you can advance to 2 pounds, right? And so on. The same thing with exercise. The more you do, the more you're able to do. One of my patients said to me, Doc, I remember. It's like you said, the more you do, the more you want to do, and the more you can do. And that's very, very important. So remember that and try to move, exercise. American Heart Association recommends 150 minutes of moderate intensity exercise like walking per day. And that's what I recommend to my patients. 150 minutes is 30 minutes, 5 days a week, 50 minutes, 3 days a week, about 20 minutes every day. Whatever combination you choose, just go for it. And remember, you can break it down. If you're really tired from cancer treatment, you can say, I'm going to do 10 minutes 3 times a day. Absolutely fine. You can break it down however your body allows you to. You rest and then you pick it back up. Okay. So exercise is particularly important and relevant. Helps not just your heart, but your entire body. So it's really important.
Thank you so much, Dr. Toshi. Thank you everyone for joining us. I know we've got lots more questions. We may need to do a part 2. We'll follow up with you via email. We really appreciate you being here today. Please take a couple of minutes to complete our evaluation, which we'll also send with the recording, and share your feedback about today's session. Again, thank you all. Thank you, Dr. Toshi and the Leukemia Lymphoma Society for collaborating on this wonderful program.
Thank you so much. Thank you, everyone. And thank you again, Amanda and Savina. Thank you.
Thank you.